Good morning, everyone. Today, the title of my topic is prediction of acute kidney injury in cirrhosis. I'll be talking under the following headings: AKI definition and HRS staging, causes of acute kidney injury in cirrhotics, novel biomarkers, pathophysiology and risk factors of HRS AKI, prevention and treatment of HRS AKI, and predictors of AKI in cirrhosis patients, and then finally the conclusion. Now let's talk about a little bit in the background. It started about 2 decades back in 96 when HRS type 1 was defined by the ICA, where the cutoff of creatinine was kept as 2.5 milligram per deciliter. Then in 2004, ADQI defined rifle diagnostic criteria for AKI. Then it evolved to in 2007, Aiken modified rifle diagnostic criteria for AKI to form the Aiken diagnostic criteria. In 2011, the ICA and ADQI defined AKI, wherein there was it defined by the increase of serum creatinine by 0.3 milligram in less than 48 hours or more than 50% from the baseline. 2012, KDIGO modified the rifle and Aiken diagnostic criteria for AKI to form the KDIGO diagnostic criteria. And finally, in 2015, the ICA further defined AKI for cirrhosis, wherein the other serum creatinine was obviously kept as a diagnostic criteria, along with other parameters which were defined as baseline serum creatinine, staging of AKI, progression and regression of AKI in response to treatment. Then there's the evolution in the field of biomarkers, which actually help in the detection of susceptibility for AKI, differentiating between functional and structural causes of AKI, and detection of inflammation. So in 2015, the ICA revised the definition criteria for AKI in cirrhosis, and they removed the traditional requirement of a creatinine of 1.5. The new definition, combining the Aiken, the rifle, and the ESRD, comprises of 3 stages. That is the stage 1, increase in the creatinine of 0.3 milligram per deciliter within 48 hours, or increase in 1.5 to 1.9 fold from the baseline. Stage 2 is increase in creatinine by 2 to 2.9 fold from the baseline. And stage 3 is increase in 3-fold from the baseline, or a creatinine of more than 4 with an acute increase of 0.3 milligram per deciliter, or initiation of renal replacement therapy. AKI affects close to 50% of hospitalized patients with liver cirrhosis and leads to the development of acute kidney disease and de novo chronic kidney disease. The terms HRS1 and 2 are now replaced by HRS AKI and HRS non-AKI. HRS AKI refers to an increase in the creatinine of more than 0.3 milligram per deciliters within 48 hours, or what we had discussed, or an increase in the serum creatinine of more than 50% using the last available value of the outpatient creatinine within 3 months as a baseline value. And HRS AKI can be diagnosed only in a patient with decompensated cirrhosis with an AKI without improvement in kidney function after the diuretic withdrawal and plasma volume expansion with albumin infusion for 2 days. It also necessitates the absence of shock, nephrotoxic drug exposure, or structural kidney disease which is indicated by proteinuria of more than 500 milligram per day, microhematuria of more than 50 RBCs per high power field, and abnormal renal ultrasound. Here we can clearly see how the survival is affected in patients who get inflicted with AKI. Now, HRS1 is, we've discussed is HRA AKI, and we have discussed the staging also. HRS2 is HRS non-AKI, which is further divided into HRS AKD, whereas where the GFR is less than 60 ml per minute per 1.73 meter square for less than 3 months in the absence of other causes. And HRS CKD is eGFR of less than 60 ml per minute per 1.73 meter square for more than 3 months in the absence of other causes. The HRS classification follows, HRS AKI follows the same staging system as proposed by the ICA, but divides the stage 1 AKI into 1A, that is serum creatinine of less than 1.5 milligram per deciliter, and 1B, with a serum creatinine of more than 1.5 milligram per deciliter. However, the reduction in the urine output is not included in the current HRS AKI definition. Multiple studies have shown that this revised AKI staging system closely correlates with the patient's survival, and it is an excellent prognostic tool. It is important to mention that all definitions of AKI in cirrhotic patients still uses serum creatinine despite of its multiple limitations in liver cirrhosis. One of the major drawbacks is the time lag between the onset of kidney injury and the rise in the levels. And that period may actually be potentially represent an important therapeutic window where a pathophysiological driver of HRS can be reversed. Another limitation is that it obviously lacks the discriminatory ability with regards to the etiology. Now, how do we basically differentiate between the pre-renal AKI, the ATN, and HRS? In all the three categories, patients presents with hypotension, and there could be history of nephrotoxic in ATN with a mixed picture. Ascites is a must in HRS patients. We see response to the fluid response in the patients with pre-renal AKI. We feel to talk about IVC, we see that it's more than 50% collapsing in pre-renal AKI and less than 2.5 centimeters. And in HRS, it's usually more than 2.5 centimeters with less than 50% collapsing. With the urinary sediments of, with the negative urinary sediments in the pre-renal or HRS group, and a granular cast in the group of ATN. Urinary sodium, having raised urinary sodium again in the ATN group, and highly raised NGAL in the group of ATN patients. And patients with liver disease have now limitations of serum creatinine, which we were discussing. They have sarcopenia, decreased hepatic synthesis of creatinine, and increased tubular secretion of creatinine, which actually translates into an overestimation of the GFR. Further, the ascites increases the total volume of distribution of creatinine, again leading to an artificially reduced serum creatinine. Other biomarkers such as cystatin C will allow early diagnosis and management of AKI in this population. Now, these are the common causes and their differential diagnosis and their management. The most common is pre-renal AKI, which we'll get to know with the history, clinical history, and diagnosed with the POCUS findings and bland urinary sediments, where obviously the management is a discontinuation of the diuretics and repletion of the intravascular volume, which is preferably with albumin in these patients. Ischemic ATN and toxic ATN. Ischemic ATN is if a patient is having prolonged pre-renal insult, like a GI bleed leading to hypovolemic shock or septic shock, or due to SBP, which is again diagnosed on clinical history and granular cast on urine microscopy. And again, the treatment is conservative and depending upon need for RRT and diuretics withdrawal if the patient is in fluid overload. Toxic ATN is we have to take a history of nephrotoxic medications, like if a patient is taking vancomycin or quinolones or any nephrotoxic agents. Again, there would be granular cast on the urine microscopy. Treatment remains the same. Then bile cast nephropathy is again deposition of the intratubular bilirubin cast in severe liver failure patients. Typically, the bilirubin levels are more than 10 milligram per deciliter, and we see bilirubin cast on microscopy, urine microscopy. Treatment remains liver transplant and diuretics for if the patient is volume overload, and renal replacement therapy. HRS AKI we'll be further discussing. Cirrhotic cardiomyopathy is again one cause where there is hyperdynamic circulation which leads to activation of the RAS and CNS, sympathetic nervous system activation, cardiosuppressants such as nitric oxide and inflammatory cytokines. Echocardiography is how we diagnose it. Again, the treatment remains transplant, diuretics to reduce the preload, and vasopressors. Abdominal compartment syndrome is when the patient is having tense ascites, which causes severe intra-abdominal hypertension and renal vein congestion. Herein, if we see that there will be sustained intra-abdominal pressure of more than 20 mmHg. So management remains large volume paracentesis. Secondary IgA is a decrease in the expression of the hepatic siloglycoprotein receptor, leading to defective IgA glycosylation, wherein we see hematuria in urine routine and proteinuria on urine analysis, and then on renal biopsy it is finally proved. Again, the treatment remains liver transplant in such a group. Now the kidney-related causes is membranoproliferative GN, MPGN, which is related to hepatitis C virus, which leads to cryoglobulinemic vasculitis, or hepatitis B virus also causes it. So there will be again hematuria, proteinuria, active sediments on urine analysis, and positive HCV RNA or HBV by PCR, and the treatment remains treating them with the directly acting antiviral agents. Now, acute interstitial nephritis is, we have seen fluoroquinolones, levofloxacin, moxifloxacin can cause, and PPIs can cause, which are used for GI prophylaxis. Again, here the clinical history along with the sterile pyuria on urine analysis, along with WBC cast on urine microscopy will help us in diagnosis, and then the treatment remains withdrawing the offending agent. Obstructive uropathy, midodrine is one which causes it, and how we diagnose it by examination, history, a scan, POCUS along with renal ultrasound. The treatment is urinary catheterization along with withdrawing the offending agents. Now, differentiating different causes will be, there are the by clinical assessment, which remains very important, then conventional diagnostic tools, novel biomarkers, invasive hemodynamic measurement, and non-invasive hemodynamic measurement. Now, if we talk about novel biomarkers, cystatin C, it is basically a cysteine protease inhibitor, which is produced by all the nucleated cells of the body, and it is filtered by the glomerulus and metabolized in the tubules. So, and what is basically the advantages are that it is not affected by the muscle mass, age, and diabetes, then the serum creatinine. It is useful in the AKI prediction and prognostication. MELD cystatin C improves the accuracy of the mortality as well. Equations which are based on combining the both, that is cystatin C and creatinine, least biased in assessing the GFR in cirrhotic patients. It's a marker of tubule damage, and it is also useful for differentiating between a pre-renal and a pre-renal or 18. Basically, it becomes really elevated in the 18 group. Greatest accuracy among the monomeric NGAL. Now coming on to NGAL. NGAL is urinary NGAL. It is produced by neutrophils and epithelial cells, including the kidney tubular cells, and it is abundantly present expressed in the urine following ischemic injury. So there is a greatest accuracy among the monomeric NGAL, interleukin 18, and other conventional biomarkers for differentiating between the ATN and other causes of AKI when measured at day 3 in the decompensated cirrhotic patients. Predictive of a 90-day patient transplant survival and prognostic factor for mortality in ACLF. It starts to rise nearly 3 hours after the renal injury happens. But it has its little bit of pitfalls, like there's lack of standardization and uncertainty regarding the cutoff values, and unavailable in many countries, and also it's quite expensive as well. Now, urinary kidney injury molecule is another one, which is a transmembrane protein that is upregulated in the proximal tubule, and it is shed in the urine in response to ischemia. Again, it is useful in differentiating the types of AKI and predicting the patient mortality. It is highest in the ATN group, but it does not have very good sensitivity and specificity. Then there are urinary liver fatty binding acid binding protein, that is LFABP, intracellular lipid chaperone involved in the lipid mediated processes. It's pro-inflammatory cytokine expressed in the proximal tubular cells, and it is again upregulated in the acute ischemic injury. So, but there are not much studies on these markers yet. We cannot actually really predict the mortality or kidney outcomes as yet. Now, invasive measurement of filling pressures can provide valuable insight into the cause of renal dysfunction, and can again distinguish between the cardiorenal and hepatorenal syndrome in cirrhotic patients. Pelayo et al. Performed right heart catheterization of 127 cirrhotic patients. 62% of patients have elevated wedge pressure of more than 15 mmHg and were subsequently switched from volume expansion to diuresis. Renal function improved, indicating the potential significant role of accurate intravascular volume assessment using the invasive hemodynamic monitoring in guiding therapy of AKI in these patients. Now, Prem Kumar et al. Validated the use of inferior vena cava diameter and collapsibility index for volume assessment in cirrhotics by correlating with the central venous pressure by right heart catheterization. Wells et al. Showed 23% of patients had improvement in their renal function following a point of care echocardiography guided therapeutic maneuver like volume expansion, diuresis, or paracentesis. VEXUS, that is venous excess ultrasound, it detects the flow abnormalities in the hepatic portal vein and kidney parenchymal vein and can assess renal venous congestion in real time as well as effect of decongestant therapy. Then point of care ultrasound, POCUS has recently emerged as an important non-invasive diagnostic tool to assess the intravascular volume status in cirrhotic patients with AKI. POCUS can actually accurately measure IVC diameter and percent IVC collapsibility, which are surrogates for right atrial pressure measurement, and therefore it may differentiate between the volume depleted and repleted states. This is how the IVC diameter correlates with the respiratory variation and the CVP. When the IVC diameter is less than 1.5 centimeters, it will be collapsing, the respiratory variation, and CVP corresponds between 0 to 5 centimeter of water, and so on. When it is more than 2.5, the respiratory variation becomes less than 50%, and the CVP goes up to high to between 16 to 20 centimeters of water. And there was a study in which POCUS had been proven to better characterized intravascular volume and prevented the misclassification of AKI in 53 cirrhotic patients. Some authors have advocated for multi-organ ultrasound, including a combined ultrasonographic assessment of lung, internal jugular vein, left ventricular volume, stroke volume, right ventricular size, superior vena cava, and femoral vein Doppler. This was a study on prediction of AKI in cirrhotic patients, where a new score combining renal, liver, and inflammatory markers was studied, which they had seen there was total of 42 patients who had developed AKI. Higher baseline serum creatinine, more severe liver disease as assessed by the MEL score, and higher neutrophil to lymphocyte ratio were independently associated with AKI. So basically, it was a model, a risk score was created, combining these 3 points, allowing 3 points if the serum creatinine is higher than 0.9, and 1 point if modified MEL score is higher than 21.7, and if and another point when the neutrophil lymphocyte ratio is higher than 6. The area under the curve of the risk prediction score for AKI was 0.861. So this has a good diagnostic value if we combine these in this paper. Then there was another paper where there was a role of biomarkers as a predictors of acute kidney injury and mortality in decompensated cirrhosis. There, the plasmas, combining plasma cystatin C, urinary NGAL, and substitution of serums of cystatin C for creatinine significantly improved the MEL score accuracy for mortality prediction. The incidence of AKI is high and is associated with high mortality in decompensated cirrhotic patients. So plasma cystatin C and urinary NGAL are useful for early detection of acute kidney injury. This was again one paper which was, there was a development and validation of model to predict acute kidney injury in hospitalized patients with cirrhosis. Basically admission data from the prospective cohort of the hospitalized patients with cirrhosis without AKI on admission was used for the derivation, and AKI development in the first week was captured. Independent predictors for AKI on multivariate logistic regression were used to develop the prediction model. In the derivation cohort, the mean age was 57 years. The MELD was 17, and 59 patients developed AKI after a median of 4 days. Admission creatinine odds ratio of 2.38 per 1 milligram per deciliter increase. INR of 0.1 with the odds ratio of 1.92 for 1 unit increase, and WBC count with the odds ratio of 1.09 per 1 into 10 raised to power 9 increase were independently associated with AKI. These variables were used to develop a prediction model in the validation cohort, and a model consisting of admission creatinine, INR and WBC count can identify patients with cirrhosis at risk for hospital AKI development. On further validation, our model can be used to apply novel interventions to reduce the incidence of AKI among patients with cirrhosis who are hospitalized. Again, there was another paper which was very recently published where urinary NGAL predicts the short-term outcomes in decompensated cirrhosis with acute kidney injury. Here, a total of 110 consecutive patients were taken, whose mean age were 44, and where majority were males, and the most common etiology of CLD being alcohol. Pre-renal azotemia was the most common of acute AKI, and urinary NGAL was significantly elevated in ATN patients, then in HRS group and the pre-renal group. 44% of patients with ATN and 76.3 patients with HRS and none with PRA required dialysis. So a total of 79.3% patients with HRS and 76% with ATN died. Urinary NGAL was significantly higher in patients who required hemodialysis than in those who did not. Both the urinary NGAL and plasma NGAL are significantly elevated in patients who died. So urinary NGAL can differentiate between different types of AKI in cirrhosis and predict the need for renal replacement therapy and mortality in decompensated cirrhosis with AKI. This was one more interesting Delhi model which was developed by Jatin Agarwal et al. From Gangaram. This was a new tool for predicting response to terlipressin in HRS group, HRS AKI group. So here in this also they basically created a Delhi model wherein they combined the serum creatinine, the CTP score and DCD4, which is serum creatinine at day 4 of admission. So baseline creatinine, CTP score and DCD4, that is creatinine value at day 4, independently predicted response to the treatment in the HRS AKI group. So this may further guide the terlipressin treatment in these patients, but needs further validation. Now, will not go into much detail of the pathophysiology. We know liver damage, cirrhosis causing portal hypertension, then ultimately causing a severe splanchnic vasodilation, and then renal vasoconstriction, and finally a patient getting HRS, hepatorenal syndrome. So what are the risk factors? Predisposing factors includes higher baseline creatinine, lower baseline mean arterial pressure, and underlying cardiac dysfunction. Patients with cirrhotic cardiomyopathy have persistent hyperdynamic circulation, which eventually leads to a diminished cardiac reserve and progressive renal dysfunction. So very important to know what are the common triggers for HRS AKI. They are bacterial infections, which are mainly SBP, large volume paracentesis, GI bleeding, or acute alcoholic hepatitis.
These events decrease the effective arterial blood volume and contributes to renal vasoconstriction, which is a hallmark feature of HRS. What histopathological changes we see in HRS AKI group? It's a purely AKI is a functional disorder of kidney and does not involve any structural damage. But there is a recent evidence which suggests that there's often a discrepancy between the clinical and the histological diagnosis. Studies have shown, Travelli et al. Showed that out of 18 patients with a clinical picture compatible with HRS, 13 had chronic tubulointerstitial injury, 12 had acute tubulointerstitial injury, and 10 had glomerular lesions, and 12 had vascular disease. So sustained ischemic injury from renal vasoconstriction and nephrotoxic injury can cause intrinsic tubular injury. This explains the low likelihood of renal recovery with a prolonged duration of AKI which is behind the recommendation of a SLK for patients who become dialysis dependent for more than 6 weeks. Now, HRS AKI is easier prevented than treated. Norfloxacin SBP prophylaxis has been used in selected patients with cirrhosis, and it decreases the 1-year probability of SBP and HRS and improves the 1-year survival as compared to the placebo. Quinolones can cause AKI themselves, mainly the acute interstitial nephritis. In patients with SBP, the incidence of HRS AKI is lower with a concomitant use of antibiotics and albumin compared to antibiotics alone. The recommended dosage is 1.5 grams per kg body weight on day 1 and 1 gram per kg on day 3, up to a maximum of 150 milligram per day and grams per day and 100 grams per day respectively. There was a recent meta-analysis which was a combination of 4 RCTs, wherein the administration of albumin with antibiotics reduced patient mortality from 35.4% to 16% and reduced the incidence of renal improvement from 30.6% to 8.3%. NSAIDs should be avoided in all cirrhotic patients, especially those with late-stage disease, as the NSAID use is associated with HRS AKI development. In HCV-naive patients receiving HCV-infected organs, timely access to the direct acting antiviral agents is essential in preventing the development of acute HCV-induced glomerulonephritis. Now, management is divided into, we've discussed the preventive measures. Now, the supportive care, the pharmacological management, and the non-pharmacological management. The general dietary recommendations consist of sodium restriction for such patients with volume overload and cessation of alcohol consumption. Protein intake should be individualized in each patient according to needs, comorbidities, presence of hepatic encephalopathy, and kidney function. Use of NSAIDs, diuretics, non-selective beta blockers, RAS inhibitors, other nephrotoxic medications which can adversely affect the renal function should be stopped. Treating any possible infection, especially SBP, is a critical initial step of conservative management. Routine tests that should be performed include all the tests like imaging, abdominal chest imaging, blood and urine culture, as well as cultures of the ascitic tap. Now, management of AKI in patients with ascites. If a patient of cirrhosis has ascites, we first go for a clinical examination and see if there is lower extremity edema. Usually, if there is no lower extremity edema, it could be pre-renal AKI, which responds to fluids. If there is a lower extremity edema, it should be treated with albumin for 1 day, and then if the AKI persists, then we should be assessing the volume status. And for a volume depleted patients, they should again be given albumin. But for depleted patients, we should go for a urine routine examination, wherein we should see the presence of granular cast, hematuria, and history of nephrotoxic agents. And if it is HRS, then it should be treated with vasoconstrictor along with albumin. Careful clinical examination and frequent assessment of the intravascular volume status by measuring the IVC diameter and POCUS and a bedside echocardiogram is needed to avoid volume overload from overzealous albumin infusion. This is again if a patient an algorithm wherein a patient when a cirrhotic patients come with an elevated creatinine, we should see if the patient has a presence of ascites. or how is the improvement with the administration of albumin? What are the signs? Are there any signs of shock, nephrotoxic agents, and signs of kidney disease? And we should assess and we should see the baseline creatinine and rule out any possibility of other renal diseases. If this creatinine is low, and if the patient is meeting the AKI criteria and fulfills the criteria of HRS, they should be treated accordingly. If the patient is in the ICU, should be treated with norepinephrine along with albumin infusion. And if non-ICU, then terlipressin should be used with albumin. And if still there is no improvement, then liver transplant is the management. The mainstay of pharmacological therapy in AKI consists of plasma expanders and vasoconstrictors. The combination of albumin and vasopressors is the treatment of choice for HRS AKI according to American AASLD and European Society for Liver Disease. Now, what are the factors which actually affect the response to vasoconstrictors? That is the timing of the initiation after diagnosis, degree of renal dysfunction, degree of cholestasis, post-constrictor increase in the mean arterial pressure, reversal of the underlying triggers, and presence of underlying cardiomyopathy or portopulmonary hypertension. This was diagrammed from Jason, and which the determinants of HRS reversal, which if the patient has a baseline CKD or a cirrhotic cardiomyopathy, the chances of reversal is less, and along with worsening hyperbilirubinemia. Now, albumin, the lack of improvement in the renal function following an albumin challenge of 1 gram per kg of body weight per day for 2 days is currently requirement, which we've discussed. First, the albumin was thought to decrease the burden of the systemic inflammation and oxidative stress by acting as a scavenger and a metal ion chelator. It plays a role in the immunomodulation also by binding to the endotoxin and decreasing the TNF-induced NKF beta activation. It also helps stabilizing the endothelium, maintaining the capillary integrity, and decreasing the permeability. It has other positive effects like it has a positive cardiac ionotropy, anticoagulant and antithrombotic agent, and binding in transport of drugs, iron, bile acids, and bilirubin. And it is currently recommended as a first-line agent for treating HRS. Then Selro et al. Performed a meta-analysis of 19 studies, clinical studies, with 574 patients.
I have to summarize that